Welcome everybody to another Insights World Tour. Tonight we're in Canada. Welcome everybody. I'll unmute. This is to our another Ortho Insights World Tour. We are in Canada tonight. And my name is Brad Petrosor. I'm a professor of surgery at McMaster University and work with Mohit Bhandari and working with the Ortho Evidence team for this. And so we'll just go over a few housekeeping issues and as we welcome everybody in. So tonight's event is recorded. During the presentation period, we ask you to mute and go off video, but during the discussion period, please feel free to turn your video on and unmute and ask your questions. And if you want to ask questions, you're more than welcome to raise your hand or put them in the chat box or in the discussion period or throughout the evening. If there are questions, please feel free to just unmute and say them. And we will provide full recordings to the participants after the events are all completed. So you'll get those recordings. We'd like to say that the World Tour is really limited capacity online live events, and it just gives everybody a really hopefully an interactive experience. We really want you to participate, ask questions, share your videos so that we can really allow everybody to interact with our leaders and peers from across the world. So please feel free about that. And as we move on for tonight's World Tour, I'm very pleased and honored to present Darryl Yardley, who's a consultant and physiotherapist and a professor at the Department of Physical Therapy at Western University in London. And tonight's theme is about modern healthcare as a team sport, but is it? And it's really going to focus on, are we playing together as a team? What happens when patients are discharged? How do we bring everybody together for optimal patient care? And I'm really looking forward to this presentation and interactive experience. And I really thank Darryl for his time tonight and for his presentation. So Darryl, so to you.
Okay, great. Thanks, Dr. Petrosor. And Abby, I know you're behind the scenes, so thanks for putting this together with me over the last few weeks. And thanks to Dr. Bhandari and his team at OE for putting this on and the invite to come back. So what I'm going to suggest that we do too is I'd like to keep this, as Dr. Petrosor suggested, let's keep it as interactive as possible. I actually do recognize quite a few people on the call, but maybe let's just make sure our chat's working as I'm kind of going to flip over here and share my screen. But I'm actually just curious, maybe type in the chat, what's your discipline? Are you a physician, general practitioner, surgeon, and where are you, physio, where are you calling from? Are tuning in from? I'm actually just curious to see where we are across the world. And as you guys are doing that, you're going to see me keep looking up. Hey, Xavier, recognize you. I got my chat on a separate screen here, so I'm not ignoring you, but I'm definitely going to keep my eyes on this on the chat as we go through. And one of the things that I thought of when we actually, we're trying to think of a topic that would be, engaging and really drive conversation. I know, having the privilege of working with Dr. Bhandari and Dr. Petrosor for quite a few years, it's, a lot of the things that we do to advance healthcare is really just by having really good conversations with like-minded people who are actually motivated to change the current space that we all work in for the better. So we really thought about, there's a lot of evidence out there around interprofessional collaboration, but for someone like myself who's been in the private sector for really since I graduated, it is a lot tougher when you think about collaboration. And one of the big sort of thought processes that we want to use to drive our conversation tonight is around transforming care through collaboration. But what does it actually look like in the private sector? And I've been very fortunate, and I'll kind of disclose some of these components. I've been very fortunate to work with many orthopedic surgeons and neurosurgeons over the years, and I kind of really feel that it's advanced a lot of my skill set, but not so much just my skill set, but just the ability that I've had to provide a great experience to patients, only because I have the opportunity to collaborate so closely with, the individuals who have operated on that patient, or who are, working collaboratively with us in the conservative care to try to determine whether a patient may or may not be a good surgical candidate. So what I'm hopeful to share with you guys though tonight is just a little bit of my experiences, but I'd love to see what we can do, what we can think about, and what kind of conversations we can have about how do we kind of replicate this experience that I've been so fortunate to be a part of. So just to kind of get us started, I wanted to sort of get a sense of, where is all of this coming from? Just looking at who's on the call tonight, and there's many exceptional people that I've recognized here as well. We've got orthopedic surgeons on the call, we've got sports physicians on the call, which is excellent, and we've got lots of PTs on the call as well as a lot of other health disciplines. So the interesting thing though is it's well known. The World Health Organization has identified collaboration, really to have an opportunity to improve patient outcome, as well as actually when you really think about the cost on the healthcare system. And it is always a little bit interesting though, when you think about it in the private sector, because we often kind of look at the private sector as well. If a patient, let's say they go and have surgery, they get referral over to see physiotherapist or the, rehabilitation. And all of a sudden, well, their funding sort of ends at a point of, well, their benefits have run out. And I really want us to sort of move away from just that concept of there's a finite end in sight, and how do we work collaboratively to maybe not always have that, same desired focus. Well, this is as far as I could get them, so I guess we'll have to kick them back into the public sector. And, really that's the experience that unfortunately many of us do have. But I think we can do better, especially when you put, the minds that we have in this call together tonight. Okay. So just a quick, couple quick things. I think most of you, and again, Brad, thanks for the intro. So I guess, my sort of focus tonight is, yes, I do own a clinic. So I do see many things from, practicing myself as a consultant, and working with many clinicians across the country, as well as many clinic owners. And then really just having an opportunity, again, to do quite a bit of work in the hip and the spine world. So hopefully I can bring some of that experience to our discussion tonight. But what I want to do is to kind of get a sense of, who are people working with right now? So if I was to ask you sort of in clinic, who currently is on your team when we start thinking about your collaboration in the private sector? So would it be, is it physio only? Is it physician working with physios? Is it a multidisciplinary team inside of your clinic? So there's PT, chiro, massage therapy. Maybe just share who's on your team. Let's kind of get a sense of where we are. Oh, good. We have some physiatry on the call. Excellent. Very good. Don't be shy. Fill up the chat. All right. So what kind of, as people are thinking, oh, good. So you got some family physicians, nurses, excellent. Great. And I can honestly say, like, nurse is a big gap for us sometimes in private clinics. And people are seeing, for me in Ontario, where I am, is lots of people are still seeing nurses for, wound care still, let's say after a fairly large trauma. And we don't really have a lot of collaboration with nursing. And it's certainly an area of opportunity, that's for sure. So as people are kind of, throwing in some points into the chat there, what I wanted to share with everybody is kind of what I always sort of suggest and teach as far as what we see in the private sector. And everything for me is, how does a patient enter my clinic, where I would see them as a PT, and kind of how do they kind of work through this journey in order to make sure that we actually have them, get to a point of graduation, and we would consider that a successful graduation, as opposed to, patient just, comes to the clinic for a session or two, and all of a sudden they just stop coming. And then we don't know what happened to that particular individual patient. But again, I can always think about, what about the physician who may have made that referral into the clinic, whether it was post-surgically, whether it was actually just to see whether there was a need to go from, let's say, physiatrist or sports medicine physician, to a surgeon. Let's see how they did in conservative management first. And we don't have any information to pass back and forth. And one of the things that we actually see, if we were to sort of base this as a funnel in the private sector, what we often see is we have a nice sort of, input mechanism into our clinics as far as, let's call these little arrows, or new patients. But what actually comes out of the clinic on a successful graduation side or discharge side is actually quite narrowed. And one of the things that we're really looking for is that through this interprofessional collaboration and really looking and involving the patient in the decision making, so really driving home this patient-centered model of care, how can we kind of rejig that funnel? So we actually see at the end, the reason there's these cakes here is that, and for many of us who've had great outcomes with patients, they're the ones that tend to send us those thank you cards. They usually bake us some treats. They drop off. For all the docs I work with, they always tend to get alcohol. I don't. But at the end of the day, it's a nice recognition, no matter which way we look at it. And that's really the focus that we want to think about is how do we improve sort of that output mechanism of people who are successfully moving through a plan of care. Okay. So, let me just funnel back into here for one quick second. So if I was to sort of present again back into the chat for a second, what would you sort of identify as the best benefit to interprofessional collaboration in your experiences so far with patients in the private sector? So what would it be? And Dr. Cruz is on the call and she has a large team, which is excellent. Very good. So what would you say? Let's throw them in the chat. And maybe if, in some cases, if you don't really have a lot of experiences, let's say in the private sector, working in a collaborative team, that's actually okay. What do you think what would drive you enough from a benefit perspective to put forth the effort? Shorter wait time. Actually, that's really good. And it's interesting too, right? Because especially if we think about it in the private sector, let's say referral into a rehabilitation clinic, it's not uncommon to have a wait list beyond weeks. And in some cases, some of these patients post-surgically can't wait weeks to receive care. And is one thing that, again, how do we prioritize in certain clinics? But if there's no collaborative real role, how do you triage that? And again, this is something I've learned, and I certainly don't, I really respect how difficult it is to triage patients when you're getting, as an orthopedic surgeon, 50 new referrals a week and having to triage, who is the highest priority. It's tough. And again, just another opportunity for us to all work collaboratively to actually help triage from an acuity perspective, or who needs to see, which specialist, right person, right place, right time, right? So again, a whole component around healthcare reform. And again, another one, you guys are all quiet tonight, so fill up the chat. So let's see. So again, one-stop shop from a patient's perspective. And that's actually a really critical point. And there's some evidence to actually support that. Okay. And I do think one of the things that's very important for us to consider, though, is, what are the benefits? And it's important to really dig deeply into the benefits. And then we're also going to end with, what do you think is the potential biggest barrier for us to maybe discuss before we wrap up tonight? Because the risks and the benefits, we have to really look at that. Because let's be honest, we're all extremely busy. And yes, we all do have patients' best interests in mind, but we don't have enough time in our days. We don't have enough time in our week. And there's lots of other things that are happening around us, both personally, professionally. And let's be honest, we're in the middle of a pandemic and it's now 2 years. Okay. So here's a few things of what we know. And I don't think I'm sharing any information to this group that, we need to go line by line. I'm going to raise a couple of thoughts though for us. So again, here's that piece around access to care, but also for me, I'm quite motivated by right person or right provider, right place, right time. And I'll just give you an example of that. We had seen a patient, I did a consult for another physio colleague of mine, and this patient's been in clinic for X number of weeks, plateaued with care. Next best thing is we need that patient to get over to physiatry or sports med for further expertise. And not to say that, what we did we're not good enough, but that's not the whole premise in a collaborative practice model. The premise around a collaborative practice model is to be able to work in a team and identify when people have expertise and be respectful of that. And what we do know at the end of the day is it actually improves both provider and patient satisfaction. Okay. Let's see, I'm just trying to see if there's a couple other things. And obviously there's a bias piece, as Dr. Petrosor mentioned in there too. The one thing though that I did want to kind of bring to people's attention that was about outcome focusing on chronic disease. And what's actually really interesting around interprofessional collaboration, a good friend of mine, actually, her name's Sinead DeFore, and she's a physio and she's a PhD. And one of the things that she did at Western was looking at primary care specifically and the role of physiotherapists on the primary healthcare team, looking at whether it's a community health center or it was a family health team. So the focus was primarily around chronic disease. But I think if we actually were to really take some of these concepts, principles, characteristics, competencies, we would see that this actually would really focus on improving outcome for all. Okay. Less tension and conflict amongst providers, for sure. What's the role that each of us would play? Okay. Better use of clinical resources, easier recruitment of providers. And this is actually an interesting one. And I'll kind of dive a little bit into, what the space in the rehabilitation world looks like right now, especially on the physio side. What we do know is, clinicians, a big motivator is to be part of a team, to work in a collaborative practice model. And we do see lots of smaller clinics where, you may be the only PT on staff. You may be one of, multiple clinicians, but everyone sort of works in their own little room and then they leave at the end of their shift. And there's definitely a rationale of actually seeing a lower rate of staff turnover in the private sector when we see some of these larger teams fully functioning at a highly engaging level. Now, this was actually from 2010, and it actually was a strategic working group or implementation committee in Ontario specifically. So it's from 2010. So obviously it's over a decade old now. I don't know if I love the diagram. But I'm actually curious. So this is how this group defined interprofessional care. And I don't think this is a bad representation. I just think we've evolved even since 2010, which is actually quite exciting when you think about it. But I actually be curious, what is it about this diagram that just looking at this slide, maybe is actually the part that, may have been missed a decade ago? What would you say? I had a few people look at this. They said they didn't like the design of the image. And I think, sure, in hindsight, I don't know if it was the best pictorial representation. But again, room for growth and opportunity. But what would be one thing that potentially stands out? And if no one writes in the chat, I'm gonna put Dr. Petrusor on the hot seat. What would you say? What's one thing that you think potentially is missing? Yeah.
Please write in the chat.
Yeah, Dr. Cruz has got it. Dr. Cruz has got it. Yeah, the part that's really interesting on this is the fact that the interaction with patient and caregiver is missing. And I do think it's kind of, health caregivers there. For me, I think of us as still that sort of that provider piece. And we're starting to see, especially as we go down persistent pain, chronic disease management, obviously there's a much larger role too to have caregivers involved. And during some of the time when I was doing a leadership role at one of the hospitals in Ontario, it did amaze me with just the advancement to sort of including the caregiver in that model of care. So Dr. Cruz is bang on. And I think that is the key thing. And what we do know from a patient, centered model of care these days is having them really as, almost to some degree quarterbacking their care, but it is a little bit of a stretch at times, especially when people are coming to us still seeking expertise and in some domains still seeing us really as a provider. But the one thing though that I would suggest that, we're going to move towards is we're starting to see a little bit more of a relationship centered model of care as well, when we're starting to look at the relationships we have with a lot of patients in the private sector. But what I'm going to sort of suggest too and share with you guys is some of the great work though that was happening. And many of you, if you're in the hospital as well, from the orthopedic surgery side of things, is you'll know the ministry's mandate in Ontario specifically around patient and family advisors. And one of the things that I think this group did really well though is they rolled out this IPC model, and they said, okay, well, let's actually see what patients think. And what was really nice is, what was already identified by Yara there was a one-stop shop for medical expertise and services, right? So again, that's something that patients said, this is something that we're actually looking for, okay? And unfortunately, for all of us in clinic, we may not have access to, this sort of, one-stop shop where we have all these, disciplines in this expertise. But the question is, okay, if we don't, how can we begin to move closer to that type of model? And we may never see a team as strong as, the one that Dr. Cruz has in her facility, but it doesn't mean that we couldn't figure out ways to collaborate and improve our communication with some larger centers that, us as, I always look at myself as a problem solver as a PT. So if I have to do some additional outreach, how am I going to do that? Okay. The other thing too is obviously, and I think Dr. Cruz nailed it too, is that the patient wanted to start to become valued as a member of that team, not as a patient, not as another number in the system, but again, as someone who actually is involved in decision-making, right? So again, there's that shared decision-making model that we see in patient-centered model of care. Again, a kind of an interesting piece, coming from 2010 to where we are now is, again, looking at us as providers, as coaches and as cheerleaders. And we've actually just seen this as well. In 2020, the Physiotherapy Association actually released a report, and it was actually a direct-to-consumer survey that went out asking patients, hey, what is it that you value from your PT? And a coach and a cheerleader was identified as high, actual characteristics of a PT, in addition to us being lifelong learners, as in addition to us being experts. And it was kind of interesting because, again, we often sometimes fall back into the provider-based model of care, yet we're starting to still seeing this push to move us again into this patient-centered model. So I think, this is a really good opportunity and representation for us to always think about what would it be like if we put ourselves in the shoes of that patient. Okay. And here are just a few things that I think from a provider perspective, here are just some characteristics again that came out of 2010. And this to me is less impactful is what you see when we start to dig into some of the feedback and the testimonials from some of the individuals that were physicians and therapists that were going through this particular working group. But again, I don't think there's anything here that, again, would surprise us. But again, it's about the effective communication. It's the accountability amongst all team members, access to those team members, just like we've already seen in the chat. I think Dr. Petrusor was getting to this as well, as just this respect for what everybody brings to the table. And if there is a difference of opinion, what does that actually look like? How do we manage that? How do we modify behavior? How do we reflect upon clinical decisions that we made? And again, if we have our clinical decisions are in the best interest of the patient, it's a really great lifelong learning opportunity for each of us. Okay. And I think the one thing that I've learned over the years is your ability to continuously develop as a professional can actually become quite accelerated by working with multiple disciplines, and especially surrounding yourself with people who have expertise that will literally just really help you accelerate your skill set, or even appreciate someone's skill set a little bit earlier. Let's say in a decision-making model where I make a referral quite a bit earlier to a physician specialist than maybe I would have held on to in the past. Okay, let's see. Mention the bias. Yeah, perfect. Thanks, Brad. And at the end of the day, the key thing is making sure that we are actually motivated and driven by those patient-centered goals, because at the end of the day, it is about the patient. Okay. This is something that I thought was quite powerful. And I'm sure many of you actually on this call may even know Dr. Price. And I was fortunate enough to meet Dr. Price as he was rolling out, a new family health team through McMaster. And it was interesting because it sort of also identified this change in thinking, and how maybe we were trained in school around, this approach to patient care. Instead of doing it all yourself, you harness the expertise of multiple individuals to bring the best care to the patient. Right. So not only does the patient benefit, but we too, you're sharing sometimes the burden and the stress that's associated with a lot of the work that we do. Less burnout, less job satisfaction. I think, all of us went into this field or into our respective fields to really help patients. And we were all compassionate, we have lots of empathy, but it is actually taxing on the system, right? And on what we do. And I'd actually be curious to see, even in the chat, when you think about the way that we entered into our healthcare disciplines, it was just like it was going to be easy, right? But when you really start to reflect back on it, there is quite a bit of load that we take on from, just a lot of the complexities of dealing with humans. So on that note, I'm actually curious because we're going to go into, two cases now specifically on collaborative practice models, but I'm actually curious, does anybody have any other thoughts, whether it's from the patient side or the provider side, of even just some characteristics that maybe are missed just based on how well you guys are practicing from a collaborative practice model currently? Maybe just get people to type it in the chat. If everyone's waiting to the end to chat by the sounds of it, Brad. So here's the biggest piece that I think is our breakdown. Brad, you unmuted. Did you want to add something?
No, I was just going to get you to rephrase the question because I was just thinking. So what's the biggest, is this the question?
No, I moved on. But here's the good thing. I'm actually just curious. So does anybody have any additional, whether they're provider-based or patient-based, just some other characteristics that were missed just in this, in some of the data that's been presented so far?
Oh, I see.
And as we and again, we don't have to sort of go to it right now, and just something for us to reflect upon as providers. But, the one thing that I would say over the years that we've been analyzing and where breakdowns come from, and even if you think about complaints that we all receive, the reason we often see some complaints is because of just, I don't even want to say poor or lack of communication, just potentially miscommunication, right? What we think someone heard is not what they actually heard. And there's lots of actually some pretty detailed evidence out there. And one article that I typically reference was back in like 2003. And really just even when we do provide accurate information, patients will remember, or 50% of what they do remember is incorrect. And it was a pretty well, reflected journal to look at from a peer review perspective. So it really just makes us think about, just how we communicate, and is there other more effective ways of communication, or how can we make sure that if I was to communicate, let's say at a physician level, and I make a referral to PT, how do I make sure that PT is also continuing the same, narrative when it comes to the recommendations that I may have made, or are they supportive of the diagnosis that I've made? Okay, Caroline, yeah, excellent piece around funding. Right. And funding kind of works on both sides a little bit, right? Like, is it funded within the family health team? Is it funded within the community health center? Is it funded within the hospital? But then what happens to that when funding becomes potentially your limiting factor, your barrier in the private sector? Right. And for those of us that are in Ontario, we know that, the public funding for OHIP physio, for physiotherapy isn't increasing these days. If anything, it's becoming even more of a limiting factor, especially with the pandemic. And a lot of the community-based programs that patients were to be discharged to, kind of transition to at the end of an episode of care, has been stopped, right? So again, we're sort of in a real challenging time for sure. And Caroline, if there's anything else in there that you want to share from funding, please don't hesitate. Brad?
No, I was just going to say that I just listening to you now, it always makes me reflect on the way we do things in Ontario anyway, with the WSIB approach, which is, of course, you have physios doing big assessments. I come in, we're making treatment decisions. We have really strict, not strict, but really, sort of refined goals, and they talk to the other physios and their other clinics, and then the workplace care, getting back to work. Like, it's just so integrated. And you're right. And it has to do with funding, as Dr. Courtley's talking about, because when you have a public thing and the WSIB is not involved and you go to the private sector, then there's differential care pathways, right? With differential clinics and the way of providing. And, I have some physio teams that are just very collaborative and on it. So it's, and some aren't, and it's just very, it's a little bit different, but it all comes back to funding, I think, as well.
Yeah, for sure. And I don't know, I'm even just curious, Dr. Courtley, if there's anything that you want to add, just write Mike in the chat, and I'm sure Abby and I can get you on the mic to share, because I think he raised some really excellent points. And again, at times is what Brad's alluding to as well, is depending on the funding source, right? And, which stakeholders are at the table in some of these, interactions we have with patients, it certainly sort of does guide a little bit with what we either have the ability to do or where some of our restrictions are kind of posed upon us, despite what it is, putting the patient's best interest at the forefront. And as we kind of look at this next sort of phase in this presentation, one of the things that I spent quite a bit of time with one specific orthopedic surgeon, really just doing the best that we could of kind of learning how each other practice, and then how were we supporting some of the primary care docs, as well as other physicians or other physios and rehabilitation professionals we were working with. And the one thing too, which he saw as his cornerstone as well, and I think it applies to all of us now, is really just how good communication is really that cornerstone for that patient physician, that patient therapist relationship. And that evidence, I believe, is continues to evolve, every year with multiple, peer-reviewed papers that are coming out. But I think the one thing though that he always made me aware of is just, how hard it is at times for physicians, when to communicate when follow-up is so limited, right? Or it's so challenging. We don't have enough time in our weeks, or, when it comes to a post-surgical case, for example, or a post-injection case, there's specific set parameters of when we will follow up, because, there's a large pool of patients that are still waiting to be seen in order to receive that expertise and that consultation. And again, we were talking about integrated medicine as well as interprofessional collaboration. So you can really see, again, it's just, and I actually copied this slide specifically from a presentation he and I did probably about a decade ago as well. And this is really what we pulled out from that in order to sort of really achieve that optimal outcome. But the main thing is that what we did know is when communication was strong and the narrative was on point. When I talk about the narrative, it's not where Dr. Petrosor sends me a patient that says diagnosis X, and I decide that I'm not going to agree with Dr. Petrosor. I'm going to say, well, actually, I don't think that's right. I think it's actually this, and he's missed that. That's not a collaborative practice model, right? And the problem is that it just creates another bottleneck for how patients are going to actually respond to this relationship between patient, therapist, physician, right? And what we do know is that when communication was very effective, and it was, again, it's a bad word, but or not the best word, but again, thinking of that collaborative practice model, when I support the narrative in the strategy or the expertise that Dr. Petrosor just had, it will actually facilitate and promote further adherence and compliance to, Dr. Petrosor says, this is what I believe the diagnosis is. Yeah, maybe he's still going to do some further imaging. Maybe we're going to go down a different path. Maybe we're going to see what happens with 6 weeks of physiotherapy, for example. But if I'm not actually on the same page as Dr. Petrosor, that's a 6-week wasted window, potentially. Because remember, he's still trying to make a diagnosis. Do I take this person to the operating room, or do I not have to take this person to the operating room? And he's not going to follow up for 6 weeks, maybe longer. Right. So again, it's just one of those important things for us to think about, because I do believe with the amount of access patients have to Dr. Google, there's blogs everywhere, and who knows what kind of information they're getting. Social media, you can learn how to treat your own hip these days. You can treat your own, whatever. And some of it actually is great content, but much of it is not great content. But again, it's really important for us to realize that, what people hear and when they start to trust some of their providers, and if those providers are conflicting, you can certainly guess that that's not going to be a strong satisfaction reported by that particular patient.